Thank you. Good morning, ladies and gentlemen. It's really a great pleasure to be here today. Thank you very much, Helen, for inviting me, and thank you to the Hope Foundation for this meeting. So, what I would like to express today, now in this talk, is trying to give you some examples on the initial phenotype and on the types of seizures that might affect those patients all over in the first years of life, in the first years of disease, I would say. So, the clinical findings overview, it will be the first part of the speech, and then we will move on presentation and example of seizures, and we will say something about the clinical spectrum that already has been pointed out. And again, at the last part will be dedicated to the medical management. That is very few things, but something is to be pointed out anyway. Okay, let's do a flash on what is already being pointed out. So, gelastic epilepsy is something that starts very soon in the life. From neonatal period, every child might present with hypothalamic hamartoma, might present seizures. And seizures, as you know, are gelastic seizures, unprovoked low, and might be different seizures all over the time, and we will see some examples. As already told, EEG is not very informative, even if interictal and ictal EEG. Sometimes we might have some lateralizing suspicions, but it is not for sure. And lastly, the problem with behavioral dyscontrols and the precocious puberty was already stated, and Helen will talk about it later. So why we have so many symptoms? Because we are in this region of the brain, when we have here really lots of important centers that might control the humor, that might control the here. I think this is not working. Okay, might control here you have the diabetes insipidus. Here you have some kind of behavioral and psychiatric control places. Here you have the place for the hypersomnia. So it's really, I mean, a place with a huge and with lots of points and lots of functional neurons and group of neurons. So let's move to the initial presentation in those patients. And you will see that this nice paper with 100 patients published points out that the age at onset might be really between 8 months and 61 months in patients with the seizure, the gelastic seizure only, and some more when other seizures are added to the gelastic one. So this is very interesting to see that patients with with few months of age might present really similar seizures between them, and you will see some examples. So the association of those symptoms, of those signs, is gelastic seizure, precocious puberty, cognitive and behavioral, and other seizure type is our syndrome, the syndrome of gelastic epilepsy, of the hypothalamic hamartoma related epilepsy. And we will see here some example on the, some example on the type of seizure that we are talking about. This is a patient that is experiencing one of these typical gelastic seizures. And you can see here that a very similar seizure is going to be experienced during the night. Seizures are brief, and you can see here during the night again very, very similar event, multiple per day event, these patients. This other child, Again, is presenting another event, quite well stereotyped if compared with the child that we saw before. And this other child, again, can you see it? Oh. She is, she is quite young, and she's presenting the same type of seizure than that we saw before. And what is interesting here is that the EEG does not show significant modifications. You can have some theta activity, sometimes more rhythmic, sometimes less, but it's not so clear-cut modification of the EEG activity. And this patient, you can see here, a very big hypothalamic hamartoma. This is the interictal EEG that was recorded at the time of before that seizure, and you can see here this sleep EEG that has a quite preserved background activity with the spindles symmetrical, but maybe with some slow waves. This is the awake EEG, and again here you can see a quite good activity, but some slow waves are evident, not so significant, but something is there. Regarding the age at onset and regarding the type of seizure, this is a supplementary table that was published in a paper that we published a few years ago on the intraoperatorial activity of the hamartoma. But I want to point out here the different type of seizures that might be associated with the gelastic seizures. At onset, most of the patients present with gelastic seizures, but during the follow-up, during the next months, some of the patients might present different type of seizures, and you can see here that you can have generalized tonic-clonic seizures, atonic seizures, tonic seizure, clonic seizure, so different type of seizure, and this is the evolution of the syndrome. This is the evolution of the clinical findings that we will go now. So this is another event, and you can see here very interesting that the seizure, the patient experienced the seizure, and he is doing some movements with the hands, and this was a quite stereotyped movement that he used to present every time he had seizures. And this is his fourth, not fourth vertical, this is fourth type following the Land classification hypothalamic hamartoma. And this is the interictal EEG. So despite the big hypothalamic hamartoma, you don't have real clear-cut abnormalities except for some slow waves that are very, very poor present. Okay, this is another patient that is interesting the story. She presented at the age of 6 months with seizures, and seizures were characterized by hemifacial clonic jerks. That is something that is evident, but not very frequently evident in those patients. And you can see here one of the seizure. Okay, here you can see here she's now having these spasms of the okay, here you can see here, and she's having lots of those type of seizures, sometimes associated with the lotting, sometimes not. And again, the ictal EEG does not show clear-cut modification, only some mild desynchronization if compared to the background activity. This is another interesting case because here you have the association of two things. We will see the seizure now. The patient is having those kind of seizures very frequently associated or not with the gelastic seizure, preceded or not with gelastic seizures. The seizures are occurring during sleep, but also during daytime. And here you have this, there is a clear-cut modification of the EEG, and this is quite different rather than we saw before in other patients. And the seizure here is a tonic seizure that is, you can see this hypertonus is starting, and you have a left, right hand posturing, and left leg hypertonus. So, and then it is followed by secondary generalization. What is happening in this boy is that he has a hypothalamic hamartoma over here, but together with the hypothalamic hamartoma, he has such kind of thickening of the cortex here. He was operated at first with a disconnection, but with the disconnection he had a mild reduction of gelastic seizures, but not at all on the other types of seizure. So this is the EEG, interictal EEG, and shows clear-cut abnormalities over the left temporal lobe, and you can see here again very fast spikes that sometimes you have also on the contralateral side, but much more evident on the left side, again with some also low voltage activity over here, and here you have the activity that is more prominent during the sleep. And this guy was operated, and it was removed the hamartoma and removed also the temporal lobe, and he had both pathology, hypothalamic hamartoma and FCD type 1. So it's a nice association of two different lesions. So regarding the other types of seizures, we have spasms that sometimes might occur in patients that are in the first years of life, and as already I stated, generalized seizures like atypical absences, drop attack, tonic seizures, and also focal seizures, sometimes secondarily generalized. But I would like to point out on the spasms that are quite, they're different rather than the spasm that we record in patients with the so-called West syndrome. Spasms are tends to be isolated. There is no the clear-cut slow wave on the EEG. Sometimes you have it, sometimes you don't, and sometimes they are brief, very brief movements. And you can see here that the child is having, I think, here, okay, this fast activity that is related to that very, very mild contraction. There should be some, okay, here another time. That is what we usually see in the focal cortical dysplasia when we record the spasms. So it's quite a nice picture of this condition. And this is the interictal EEG of that child. So lots of epileptiform abnormalities, and this is what has been already called the route toward the encephalopathy. So some children might evolve to an encephalopathy status related to the seizures, related to the epileptiform abnormalities. And this is his MRI with showing his hypothalamic hamartoma. Okay, this is another guy, and with again a typical seizure, but I just wanted to show you the appearance of the guy. He has also a precocious puberty and some moderate grade of obesity. And here you have another thing that was not seen before. I mean, you have the seizures that is quite typical, but you have a nice activation, a nice activity, ictal activity on the scalp, sorry, on the scalp EEG. Okay, and also this patient presented with several spikes and wave discharge that were almost diffuse with some prevalence and sometimes also what we might call infraclinical paroxysmal discharges, not associated with symptoms. Okay, this is the last case that I'm going to present you, and she has 20 years, 21 years at this stage. She is having her seizure, her typical seizure, that is associated also with some type of anxious condition. She is absolutely worried about the situation, and she has a fearful expression. She tried to cover herself, and she does not want, she feels something in the mouth, and now you can see here that the seizure is quite prolonged, and this is another a typical issue. She has always this kind of cough during the seizure, and when I tested her, she was confused. She replied to the question, but was not replying appropriately. Okay. So again, a slight different type of event. Okay, so let's conclude this first part, and in order to, I want to say that, okay, the gelastic seizure, you know, has been told today and yesterday a lot, starts in the hypothalamic hamartoma, and hypothalamic hamartoma is going to produce this kind of stereotyped epileptic seizures, but you can see here that from patient to patient you might have some slight differences in the duration of the seizure, in the ictal phenomenology, having the core of the seizure all the same, but with some different symptoms. And again, interictal and ictal EEG is poorly informative usually, but sometimes we might have some nice rhythmic activity. It's not very frequent, but sometimes we might have it. Okay, and following the natural history of the disease has been tried to, in those papers, has been tried to divide the two different groups. The first one with an early onset encephalopathy, with lots of seizure, with drug resistant and cognitive impairment, and with the onset early in the life. And the second one, maybe with less severe condition, with almost normal IQ without clear-cut behavioral disorder. Obviously, it should be important to carefully evaluate children in order to do not lose time, as the longer is the epilepsy, the longer are the seizures, and the worse might be the outcome when we decide to operate those children. And again, the natural history that is toward the spectrum, it depends also from the dimension of the hypothalamic hamartoma, from the location, from the attachment and the spreading networks that has been created all over the time. And this is what is happening, what is going to happen in patients that experience what has been called pseudo-Lennox-Gastaut syndrome. So patients that starts with gelastic seizures but develop what different type of seizures like atonic, drop attacks, tonic seizures with cognitive regression. And this is very important to know that some patients might go toward this horrible direction. And this is the spectrum of severity. From the top, the so-called benign gelastic seizure syndrome, with only events that are characterized by pressure to love. And on the lower part, the severe form that I already pointed out. Okay, let's go to the medical management. That is the last part in the last 8 to 10 minutes of my talk. And medical management is something that is really poorly reported because there is no clear-cut studies. There are no trials. There are no specific indications about the medical management in patients with hypothalamic hamartoma epilepsy. What is came out from the literature is that the choice of medication should be tailored on the type of the seizure, on the eventually presence or absence of EEG abnormalities, and along the clinical evolution, it should be modified when the new seizures might come out. What is surely evident is that very few patients respond well to the treatment. But we have to point out and we have to underline that even if they do not respond 100%, with antiepileptic medication has been reported most of the time at least a reduction of some seizures. I mean, I'm talking about tonic-clonic generalized seizures or secondary generalized seizures or tonic seizures. So there might be some kind of improvement of those kind of seizures. And, but we don't know which is the best drug because we don't know, because there are no groups of patients published on that. What we for sure know is that conventional antiepileptic medications might help, but we surely know that conventional antiepileptic medication might not help on gelastic seizures, might help only on those kind of seizures. And therefore, we have to tolerate some gelastic seizures because antiepileptic medications are not useful. There are some papers published on the antiepileptic medications, very few, some anecdotal cases. Here has been reported three patients, and in all of them has been reported a quite good effect with carbamazepine and lamotrigine. You can see here that what was not treatable was the pressure to loaf daily, but all the other seizure types were quite well controlled. This is we don't know why, but there's a speculation that there is here the presence of very small hypothalamic hamartoma, but we know also that there are patients with a very small hypothalamic hamartoma that have more severe epilepsy. And also there is a normal interictal and ictal EEG, and all of the three patients presented with normal developmental and behavior. So again, the concept of the spectrum of severity. And if you look those papers, I tried to figure out which were the drugs that were most commonly used regarding the seizures. So if you look at here, gelastic and focal motor seizures were most commonly treated with those medications. That is what we usually do for focal seizures. We use carbamazepine, lamotrigine, and so on. In cases in which there was a very bad control, clobazam or clonazepam were added. And on the other side, in patients that presented with the more severe phenotype with generalized seizures, valproate, clonazepam, and topiramate were reported as the drug that might help more. Anyway, the combinations of the drug should not. We should not harm the child, and we do not prescribe a not rational polytherapy. Lastly, there is the alternative treatments, and there is one case published here that was operated twice, first with transcallosal approach and secondly with pterinaal approach, and in both occasions seizures were recurring, and it is stated that a certain improvement was reached with a ketogenic diet, but it was not specified which type. Again, there is this nice paper on patients, 6 patients treated with ketogenic diet, and you can see here that 4 of the patients had a quite good reduction from 50 to 90% of seizures. And it's nice to see that in this paper, authors look at also how the ketone bodies were affecting the firing, and it seems that there were a reduction of the firing in the cells in the patients that were then operated. Lastly, there are 3 papers specifically on vagal nerve stimulation, but there are absolutely no effects in most of them. Only this paper. In this paper, they reported a reduction of seizures, but it's not confirmed in the second paper, in which there were absolutely no effect, and in this third paper. Okay, let's move to the conclusion. Again, I would like to point out that gelastic epilepsy and hypothalamic hamartoma syndrome is for a great interest for us because it is a complex disease. It's a complex disease because we have several signs and symptoms, and it's real challenging to treat them both with medication and with surgery. Surely the early surgery is something that should be considered in those patients because the more seizures and the more time we leave them, the worse outcome we will have in a cognitive point of view. And because as I showed, the cascade of seizures is quite fast, and we should try not to arrive to this condition with tonic seizures and secondarily generalized seizures. Some questions remain unanswered still now, but some other things are on due. And the running down phenomenon is something that is very interesting to understand. The mechanism of secondary epileptogenesis, and also the direct role in the cognitive and the behavioral disorder. And I thank you so much for your kind attention.
Thank you very much for this nice summary. I was just wondering if you could expand a little bit about group 1, basically these children who move on to an encephalopathy, in particular how to early recognize which category patients belong to, and perhaps also what drives these phenotypes. Is this the lesion, how it looks like, or are there genetic factors? Are there any, for the clinicians, any hallmarks when you need to be particularly speeding to push them towards one of the surgical options?
Okay, thank you. For sure, what is absolutely differentiating the two groups is the age at onset. That's for sure. So the group one is composed by patients with early, very early onset. The group two, in the group two, there are also patients with onsets with a later onset in infancy or in the preschool age. So that's the first thing. I don't think that there are clear-cut associations between the type of hamartoma and the presence or not of the encephalopathy. As for my experience, we have type 4 hamartoma that goes quite well also by cognitive and behavioral point of view, and type 2 hamartoma that are not so good. I don't know your experience if is the same or not. And which was the last question? Oh.
I think basically if they are
The-
genetic, I know we are in early stages of that.
Yeah.
I mean, the question is here, we're talking about a secondary phenomenon due to seizure activity, which creates further
You have
networks.
in some patients this kind of spreading and this secondary epileptogenesis, but it may be due to the connections, maybe due to the genetics. Yes. What about the experience between the type of hamartoma and the presence or not of an encephalopathy?
I think it does correlate with size.
With size, yes, but really, I showed a patient with a type 4, and he was operated. He was disconnected twice. He has no seizures. He's absolutely a normal child with some attention deficit. So it's always this correlation. Yes, has been reported that the size is important. Has been reported on several papers, and I pointed out that one of the factors is the size, but maybe is not a rule. I don't know.
Well, okay, but you just pointed out a type 4 patient that you treated who did well. That's a good thing, right?
Yeah.
But in terms of like the untreated patients, I think size does matter.
Yeah.
But the difficulty is that although there's a correlation with early onset and the issue, it's not 100%. And the issue is we don't have predictive indications as to who is going to need urgent treatment and who, we have children who, albeit small numbers, who've only ever had gelastic seizures and have got normal IQ. And admittedly, you've got to cope with gelastic seizures, I acknowledge that, but you're weighing up the risks of intervention versus the ongoing day-to-day life. And as was pointed out yesterday, there are adults who are actually don't want any further treatment. So it's a difficulty in the first few years about deciding. I think size of lesion is one, but then that all has to come into play about what treatments you have available.
Everything is driven by the cognitive evaluation.
Yes, exactly.
Yeah.
Yeah.
Just a random thought. Knowing that much of the medical treatment doesn't do anything to the seizures and epilepsy.
On gelastic seizures.
Yes. I just wonder whether anyone has looked at what effect GnRH agonist therapy has on seizures, because it's the whole network that's disrupted. I just wonder if it's worth looking at.
As far as I know, I don't know.
There would be any
I don't
impact
know.
at all.
Through these experimental studies.
There are like a couple of patients who have been reported who seem to respond to GnRH agonists. They were obviously being treated principally for the precocious puberty, but it also did seem to impact their epilepsy. So that's kind of out there as a little bit of an unknown.
Hi, I just wanted to know if you have a patient who has only gelastic seizures. I've been always wondering because some parents report that their kid seems to have some cognitive decline because they're also waking up 15 or 20 times a night. So I wonder, do you have the impression that gelastic seizures, even if they're only gelastic seizures, have more impact on the development if they lead to major sleep disturbances? Because that's something from a pediatric point of view I would think is quite logical. If you have disturbed sleep patterns, that will cause. So would that be a cause for you to say, okay, I'm probably going on with treatment, even if the patient has only gelastic seizures and is developing more or less normal at that point? Or would you say just wait and see?
Yes, if we were talking before, if there's everything should be driven by the cognitive evaluation that should be done very on time interval. Really, my experience is that we do only one type of surgery. We do disconnection. So it's a surgery that is quite safe. So sometimes we move to the surgery easier because there is absolutely low risk in this type of surgery. I'm not saying that we are treating all the patients because sometimes this kind of surgery is not successfully, but at least in all of the patients operated, still now we operated 24 patients with the same technique. Some of them have operated a second stage, but we have about 65% of patients with in Hengel 1. Yeah.
And I think we will discuss techniques of intervention.
Yes, I don't want to discuss, sorry, the technique. I wanted to say only that as far as we use this kind of technique that is as a low-risk operation, sometimes we operate easier patients. That's only what I wanted to say.
One more question.
Yeah, this is Gayatri Vadlamani from Leeds. My question is, I know we call these as...
It's just for recording purposes, Gayatri, you won't hear it.
Yeah, this is, we label this, the behavioral and cognitive manifestations as epileptic encephalopathy. But in all other models, we correlate them with the EEG abnormalities. There tends to be frequent EEG abnormality. But here we don't. Why do we still label this as epileptic encephalopathy? Is this appropriate to do that, or are they actually lesion manifestations rather than epileptic encephalopathy?
You're right. This is not a clear-cut epileptic encephalopathy. Ingrid can say developmental and epileptic encephalopathy for sure. It's a both. It's the underlying etiology plus the seizures. Absolutely. I completely agree.
But it's also fair to say that, you know, this, with just elastic seizures, you cannot call it an epileptic encephalopathy.
Sure.
As other seizures develop, there's more widespread EEG changes, and therefore there is a correlation.
And only in that situation you can have this kind of correlation.
Yeah. One more. Yeah.
We always we try to manage the epileptic seizure. We try to manage the precocious puberty. Is there any data about attention deficit in these patients?
That's next talk.
That's the next talk. Thank you. Okay. So on that note, I think we'll break for coffee. And
Thank
if
you.
In fact, I've got a bit of leeway for lunch. I will let you have half an hour for coffee if we come back at 11:30. Thank you very much.
Okay. Excellent.